Welcome, everybody. Thanks again for tuning in. These are kind of strange times, and I think very challenging times for many of us. Hopefully, what we get to shape today is a little connection to our optometric colleagues out there, creating a mini sense of community in the midst of this virtual trade show and opportunity to receive some feedback and lectures, information on sort of the latest with regards to diagnostics, management strategies around disease. And I think now more than ever, some of these pieces we're going to be going over with regards to Retinal Reality, even more applicable, because these patients are going to be the patients that are walking in our door on a very regular basis, rather than maybe even for the majority of us that are out there, the more routine basis patients are staying at home with all of the shelter in place that we're seeing across the nation. So today's lecture is titled Retinal Reality, a wider, deeper look into disease management. We're really blessed to have on this webinar three really great faculty members. First, Carolyn Major. She is an associate professor at Northeastern in Oklahoma. Thank you, Carolyn, for being there. She may have a couple of kids in the background that chime in on it accordingly. I closed myself in a room, but who knows whether a staff person or things are going to be walking in at any moment. Steve Demko out of Swiftwater, PA. He is the owner of Advanced Eye Care Specialist and really a progressive user of technology and diagnostics, particularly with regards to OCT and ultra-wide field imaging, including using diagnostic management tools around form. And I think you'll see a bit of that. Aaron Leck, owner and director of Clearview Eye Care in California. We have the distinguishing element right now in these times of being the first state to declare shelter in place across the whole state. So without further ado, I'll hand it over to Carolyn as she dives into a lot of the clinical details around diabetic retinopathy. Carolyn?
Well, thank you, Aaron, and it's a pleasure to be here virtually with you today. And this first portion is going to focus on diabetic retinopathy. The main thing I want you to take home from this presentation is that multimodal imaging is an absolute game changer with regards to the evaluation and management of diabetic retinopathy. You're going to see lesions you weren't seeing before with clinical examination alone and in even less time. My general protocol for imaging eyes with diabetic retinopathy includes wide field or ultra wide field Claris true color fundus photography, wide field angioplex OCT angiography montage, and conventional macular OCT. So ultra wide field Claris photography is going to allow you to detect and document subtle and even peripheral diabetic retinopathy lesions so that you can go into your dilated examination knowing what fundus regions you really need to focus on. And then wide field OCT angiography montage is going to highlight subtle and even clinically invisible vascular pathologies for you, such as retinal neovascularization and retinal non-perfusion, so that you can be more confident in your staging of either non-proliferative or proliferative diabetic retinopathy. And of course, macular OCT is essential to detect subclinical macular edema and just generally classify diabetic macular edema as either being center involved or non-center involved. It also provides you with a quantitative change analysis to monitor progression over time. So ultimately, incorporating multimodal imaging into your practice is going to improve the quality of your patient care and increase your level of confidence in what you can hold on to and what you can't. This is one of my favorite tables from the 2019 American Academy of Ophthalmology Preferred Practice Patterns, and I think it does a wonderful job of simplifying the management of diabetic retinopathy. Applying this information is of course dependent upon accurately staging the retinopathy and macular edema component, which is why multimodal imaging is so valuable. There are three main paradigm shifts in the management of diabetic retinopathy that I want to point out here. And the first is that there's been a shift in classifying diabetic macular edema as either center involved or non-center involved, rather than clinically significant or not. And the main reason for this is prognostic value, right? Since eyes with center involved edema have nearly a 10-fold greater risk of vision loss compared to those without. Second is that destructive laser is being abandoned for anti-VEGF therapy, especially with regards to treatment of macular edema. There's strong evidence to support that for eyes with center-involved diabetic macular edema and reduced vision, which is usually defined as 20/30 or worse, that anti-VEGF therapy is the initial treatment of choice and superior to macular laser photocoagulation alone. I've highlighted in yellow here, and supported by the results of the drcr.net Protocol S, both PRP, panretinal photocoagulation, and anti-VEGF therapy alone, or in combination with PRP, are good management options for proliferative diabetic retinopathy. Of course, anti-VEGF therapy of proliferative diabetic retinopathy requires multiple injections, probably for life, and so compliance is definitely a concern, which limits its utility currently. And lastly, there is now strong evidence supporting the routine use of anti-VEGF agents may improve diabetic retinopathy and prevent vision-threatening complications such as proliferation or macular edema. And so the thought is, why wait to have hand motion vision from a vitreous hemorrhage, then treat it when you could just prevent it altogether? Therefore, anti-VEGF therapy may be used to treat even severe non-proliferative diabetic retinopathy and low-risk proliferative retinopathy without macular edema, and the effort to stabilize or even improve the retinopathy stage. So this first case here is a 61-year-old male with very long-standing diabetes of about 20 years and no visual complaints. In fact, his vision is actually 20/20. An ultra-wide field Claris imaging here reveals some scattered dot hemorrhages in what is likely moderate to severe non-proliferative diabetic retinopathy. But what I want to point out is that the majority of the hemorrhages are located in the periphery and would have been missed with traditional 45-degree fundus imaging alone. Although this appearance of predominantly peripheral retinopathy was bilateral, my first thought was to order a carotid Doppler, which revealed 70% stenosis on the left side only and no stenosis on the right. It usually takes about 90% stenosis or more to cause clinical features of ocular ischemic syndrome, so the retinopathy we see here is likely due to diabetes, especially since it was bilateral. My second thought was I need to watch this patient more closely, since eyes with predominantly peripheral retinopathy we know have a greater risk for progression and development of proliferation compared to eyes with hemorrhages that are mainly confined to the posterior pole. I staged this diabetic retinopathy as moderate to severe non-proliferative, but decided to follow him more closely based on the peripheral appearance every 3 to 4 months. On a few occasions now, I have discovered retinal breaks with ultra-wide field imaging and live OCT scanning that were missed clinically. Severe vitreoretinal traction may pull the retina so much that a tear forms or breaks may occur as a result of vitrectomy, which I believe is the case here. The operculated hole inferiorly blends in with this heavy PRP, creating a sort of Where's Waldo situation. The take home here is that wide field imaging makes subtle lesions, such as this hole here, easier to detect. This next case is a 63-year-old male who had already had PRP 2 years ago in the left eye. He reported stable vision and his acuity again was 20/20. At this point, he hadn't seen retina in about a year, and so his main question was whether he needed to go back to see retina or not. Here on the right-hand side is a single-shot wide-field Claris image. You can see he has pretty complete PRP 360 and minimal signs of active retinopathy, just a few scattered dot hemorrhages and cotton wool spots. But wide field montage OCT angiography tells a bit of a different story and highlights what is likely a small area of neovascularization in the superior temporal mid-periphery on the border of perfused and non-perfused retina. It also shows pretty significant peripheral non-perfusion, particularly like in this region here, here, and down here, that wasn't apparent with fundus examination and is nearly invisible with color fundus photography here on the left, aside from probably just the sclerotic vessel, which clues you into some ischemia in that region. You can see how OCT angiography shows you there's a much larger area than what may be apparent here. Contrary to what one may think, most of the non-perfusion in diabetic retinopathy is located in the mid-peripheral and the peripheral fundus, and I think that's a major take-home point here.
Carolyn, can I
Yeah,
ask you a question? Does that
certainly.
change with regards to your management of these conditions? Are you adjusting your clinical patterns? Is it making you think differently about maybe how you're going to approach that patient or what tests you might order and frequency of those tests?
Absolutely. If I see a patient that has a lot of mid-peripheral and peripheral non-perfusion, such as this eye here, and I'm on the borderline of saying maybe I should treat them or not treat them, it's going to push me towards treatment. It's also going to push me more towards PRP versus like anti-VEGF treatment. The reason being is that if this retina is non-perfused, it's probably dead and non-functioning, right? So if we kill it with PRP, that's going to decrease VEGF release and it's not going to compromise the patient's functional vision because it's probably already dead and gone. And certainly if it's something I feel like it doesn't need to go out, but I see this much non-perfusion, I'm going to watch it more closely because I know that there's a risk for progression and additional proliferation over time. The volumetric data set provided with OCT angiography imaging also applies to angioplex montage wide field imaging. So the preretinal neovascularization can be easily isolated out and identified using the preset vitreoretinal interface or VRI display as shown here on the right. The vitreoretinal interface includes data from the vitreous just anterior to the internal limiting membrane, and so in a healthy eye, it should be void of any signal in black. It's therefore particularly useful for detecting and visualizing preretinal neovascularization in eyes with diabetes or venous occlusive disease, sickle cell retinopathy, etc. This is a magnified view of that area of neovascularization, and this small vascular abnormality here could easily have been mistaken as IRMA, or intraretinal microvascular abnormalities, with fundus examination alone. And this is where the value of OCT angiography comes in, because it's able to reliably distinguish between IRMA and true neovascularization, which is preretinal and shows up on our vitreoretinal interface map. The B-scan overlay in the bottom right-hand corner here shows that the neovascular tissue is on top of the retina and clinging to the posterior hyaloid, but it's not creating any sort of vitreoretinal traction at this point. His macular OCT is unremarkable for any macular edema and reveals just a partial PVD with attachment of the posterior hyaloid to the foveal region here without any sort of traction or retinal distortion. So I diagnosed this eye as having low-risk proliferative diabetic retinopathy without macular edema. He's already had PRP, so the question here is there an additional need for PRP? Does he need more? Does anti-VEGF therapy need to be done? Or can we just rather watch this eye safely without any sort of intervention? And so I think close observation is appropriate given that the area of neovascularization is small without any sort of vitreous hemorrhage or vitreoretinal traction, and this is a compliant patient. Serial OCT angiography will also make monitoring this neovascular membrane for progression and enlargement very easy. And so my approach was to ask this patient simply to come back in 3 months, to return though sooner if he noticed any changes in his vision. Would either of you guys have managed this any differently?
I think that one of the things you highlighted here, Carolyn, is the utilization of the technology gives you confidence.
Yeah.
I would lack a whole lot of confidence in managing the case in the way that you just suggested.
Hey, Carolyn, I have a question for you. How about management of the patient? So some of the retinal specialists out there said, the number 6.3, that's the A1C level that you should be looking for. Most of the times when I'm dealing with my diabetic patients and they're coming back, what's your A1C? Well, it's 7.4. How is that? My primary care physician says this is good. And then you're looking at what you're seeing in the fundus right now that may need treatment. How are you managing these patients with the primary care doctor? And what are you telling your patients about this?
Yeah, I mean, I always communicate with the primary care doctor and recommend not only to the patient and the PCP that the A1C level, I usually say 6.5 or below, the blood pressure be less than 130/80 ideally, and then that the cholesterol levels also be well controlled. I mean, because those all play into the diabetic retinopathy that we see. I think that's a really good point. I wanted to point out some other sort of tail off or spin off features of this case. If this had been an untreated eye that didn't already have PRP, I would have referred for consideration of early anti-VEGF therapy or PRP, given the severity of mid-peripheral and peripheral non-perfusion that we saw on OCT angiography. This degree of non-perfusion in eyes with severe non-proliferative or low-risk proliferative retinopathy likely signifies that there's substantial VEGF release going on and an increased risk for progression to high-risk proliferative disease. As mentioned previously, there's a shifting paradigm towards earlier treatment of diabetic retinopathy with anti-VEGF agents to prevent vision-threatening retinopathy and progression to the high-risk stage. The presence of massive peripheral non-perfusion, such as this eye here on the right-hand side, may tip the scales towards earlier treatment versus observation alone.
I've got a question for you to follow on with that slide you just had up there, Carolyn. There's a lot that happens between what's on the left and what's on the right, right?
Yes.
So previously, it's been really that ability to see that, to measure that, to understand what's happening over time. It just hasn't been available to us. What are you doing with these patients now to get from, maybe it's not a normal, maybe you've got a diabetic suspect, right? Somebody who has some systemic risk and they've got a number of factors that really expose them to a progression path that we know will lead them to what's on the right if gone undetected, or we haven't reinforced, hey, this is where we could end up. What are you doing differently with regards to diagnostic testing, and how has it changed the message maybe that you deliver the patient so they don't get to the stage on the right?
Yeah, I image most of my diabetic patients with OCT angiography, whether it's, montage. I usually do montage if it's a patient that has diabetic retinopathy, but if it's a patient that I maybe just suspect may have retinopathy because the hemoglobin A1C is like greater than 14 or whatever it may be, then I might just do a 3 mm angio on the macular region to show me like subtle microaneurysms. And I think either the montage or a macular OCT angiography scan is going to be really useful for patient education to show them this is what's going on. And again, this is where you may end up if we don't intervene or you don't control the systemic condition as you should be. Does that answer your question?
Yeah, perfect. It sounds like you're even adjusting that as you go, right? You get a new piece of tech or you have a new understanding. And so here's a way I'm going to continue to amend and evolve that treatment paradigm.
Yeah. Stemming off of that, I also want to point out that this case highlights that wide field montage OCT angiography is incredibly useful in detecting small areas of neovascularization in eyes with diabetic retinopathy. And because of that, it aids in the earliest diagnosis of PDR possible. I truly believe that OCT angiography is going to show you the earliest proliferative retinopathy that you could possibly find. In fact, research would suggest that as well. And so recent research shows that subtle neo is actually often missed in eyes that are clinically graded as severe non-proliferative and can be detected with wide field montage OCT angiography imaging. And this next case is a 29-year-old male who had poorly controlled diabetes for most of his lifetime and was previously diagnosed with severe non-proliferative diabetic retinopathy at his last exam 5 years ago. You can see we have great compliance here. His incoming vision in the left eye is slightly reduced to 20/30. Here are the wide field and ultra wide field clarus fundus images of the left eye, and you can appreciate that there are many dot hemorrhages that extend out into the mid-periphery, along with at least one large flower-shaped area of pre-retinal neovascularization here in the superior temporal arcade. Here on the left-hand side, I've magnified the wide field image, and you can see we still have great image resolution that allows us now to visualize neovascularization on the disc and additional areas of neovascularization elsewhere. There's also some pretty significant venous beading in the retinal vasculature as we can visualize here. On wide field OCT angiography montage here on the right, it highlights at least 4 areas of neovascularization. So this one here, number 2, I think number 3, and number 4, in addition to neovascularization on the disc. There's also this massive mid-peripheral non-perfusion that we were talking about earlier. So down in here especially, but non-perfusion here, here, and in here, and up here superior temporally. Macular OCT reveals diffuse non-cystic paramacular thickening, no center involvement, of course. The posterior hyaloid appears to be mostly attached, and we can see a hyperreflective neovascular membrane here hanging across the cup like a hammock. While watching the video, we can see there's a few hyperreflective cells in the vitreous, which I think is suggestive of a subclinical vitreous hemorrhage. Here are some 3 mm highly magnified OCT angiography scans of the macula. And our patient's superficial and deep capillary plexus scans here on the top row, and then I've just put some normal eye scans in the bottom row as a comparison so that you can appreciate the pathology that's going on here. And in the superficial display of our patient up in the upper left-hand corner here, you can see there's a very enlarged foveolar vascular zone with irregular contour. There's a discontinuity and a break in the perifoveal capillary network. And this is all consistent with macular ischemia that now explains why this patient's vision is reduced to 20/30, even though we didn't see any center-involved macular edema on the OCT scan in the previous slide. There's also a rather large, I want to call it a microaneurysm, but it's really like a macroaneurysm type thing here on the temporal edge of the foveovascular zone. And surprisingly, this microaneurysm doesn't seem to be exuding any fluid since there wasn't any fluid that we could see with it on our structural OCT scan.
Carolyn, this is Aaron again, just chiming in on that last image you have. It's really interesting too as the technology is evolving here because you've thrown up an OCTA 3 mm mac cube or macular scan that's here and kind of given some different segments for the listeners and viewers here, recognizing I think that each of these segments that you've highlighted are different cross-sectional segmentation of the B scan or of the tomogram that we're looking at. So tomography and really reading the tomography becomes critical here, but the technology has even, grown since this. So on the Cirrus 6000, you've got an HD 6x6 millimeter scan that gives you as much or more detail than these 3 mm cubes. So we're finding that we don't have to now do 2 or 3 different scans. We can do one scan with the designation around high definition and it gives us a density of data that we were previously using 2 or 3 scans and then combining those to fit together.
Yeah, I think you're right on that. The newer version of the software, when you're doing the 6 mm, or I think even like the 8 mm OCT angiography scan on the macula, you're getting just as good of as resolution as I'm showing here. This is a 4.5 mm optic nerve head OCT angiography image showing you the full extent and the morphological detail that is absolutely gorgeous, I think, of the neovascularization on the disc. And we can see that that area of neovascularization is about 2 to 3 disc areas in size and clearly would classify this as high-risk proliferative diabetic retinopathy as a result. And so I just want you to take a moment to appreciate how the vitreoretinal interface display here on the right-hand side isolates and segments out this neovascularization so that you can see it in this beautiful high detail resolution. My diagnosis for this eye was therefore high-risk proliferative diabetic retinopathy without macular edema, but with macular ischemia that was causing that 20/30 vision that we saw with our macular OCT angiography scan. And high-risk proliferative diabetic retinopathy must be treated to prevent blindness. We know there's no ifs, ands, or buts. There's no options here. You've got to treat it one way or another. And the results of the DRCR.net Protocol S suggested that both PRP and anti-VEGF therapy are treatment options for patients with proliferative diabetic retinopathy. Ultimately, for this patient, though, PRP alone was performed because compliance was a concern. You know, he hadn't shown up for the past 5 years, and there was no concurrent macular edema, so we didn't have to do anti-VEGF therapy for that aspect of retinopathy here. PRP also allows for slower and more controlled contracture of neovascular tissue as opposed to anti-VEGF therapy, which may induce traction because of the fast regression of neovascular tissue and could actually cause tractional detachments in extensive proliferation cases such as this. So in summary, I hope these cases have demonstrated the power of multimodal imaging in diabetic retinopathy management and how it can improve your accuracy and efficiency in staging diabetic retinopathy. The main take-home points are: look out for predominantly peripheral retinopathy, which signifies an increased risk for progression. Incorporate angioplex montage OCT angiography imaging in your evaluation of eyes with diabetic retinopathy, since it enhances your ability to detect early proliferation and also allows you to visualize the peripheral non-perfusion that we're missing clinically. And remember, refer untreated eyes with severe non-proliferative or low-risk proliferative retinopathy and massive peripheral non-perfusion for consideration of early treatment. And last but not least, perform 3 mm macular OCT angiography scans in eyes with reduced vision and no macular edema to look for macular ischemia, which may be the cause of decreased acuity. So before I go, I want to share an interesting AMD case with you, and then Dr. Demko is going to share some additional highlights into the management of AMD. This is an 87-year-old male who complained of a recent onset central scotoma of the left eye. He had a personal history of dry AMD, and if you looked back through his records far enough, a questionable history of chronic central serous chororetinopathy. He doesn't report any prior surgical procedures aside from just cataract extraction. And his acuities are 20/25 in the right eye, 20/30 in the left. And I'm going to present this case a bit backwards and focus on the more obvious left eye first. And we can see that the left eye has some fairly severe pigmentary changes and drusen in the center of the macula. There's also some larger soft drusen here in the temporal arcades. There's no hemorrhaging or exudate that would obviously suggest that active CNV is present. But his OCT reveals substantial subretinal fluid and a multi-lobed serous macular detachment, certainly suggestive of active exudative choroidal neovascular membrane. There's also a low-lying RPE detachment with their irregular surface contour here in the nasal and inferior foveal region. Here is a series of 3 mm macular OCT angiography in-FOS displays, and we're moving from anterior here on the left to posterior on the right. And so in the choriocapillaris image, we can see there's a well-formed choroidal neovascular membrane in the inferior nasal macular region. And this is likely located in that low-lying RPE detachment that we just saw a moment ago with structural OCT imaging. This choroidal neovascular membrane is clearly active since it has this subretinal fluid overlying it. Clinically, the right eye looks similar to the left. There's some heavy pigmentary changes in the fovea and some larger drusen in the temporal macula again, but there's no macular hemorrhage, exudate, or fluid that's present here that would be suggestive of active choroidal neovascularization. OCT reveals bumpy drusenoid type RPE elevations and some intraretinal pigment migration. There's a very shallow, low-lying RPE detachment involving the foveal center, but no subretinal or intraretinal fluid. This is the 3 mm OCT angiography of the right macula. And surprisingly, there's also a well-formed choroidal neovascular membrane, similar in appearance to the left eye, that shows up best on the second display from the left here, entitled the outer retinal choriocapillaris, or our ORC slab. So our diagnosis for the left eye is exudative AMD with active sub-RPE choroidal neovascularization, since we had that area of subretinal fluid on OCT, and we also saw the membrane itself with OCT angiography. The left eye obviously requires anti-VEGF therapy, but the diagnosis and management of the right eye is a bit more perplexing. And so OCT angiography revealed that there was a well-formed choroidal neovascular membrane, but there was no fluid, blood, or exudate that was present that suggests that this membrane is probably dormant or non-exudative or quiescent. It goes by a lot of different terms, but basically sleeping and quiet. For these types of choroidal neovascular membranes, I'd recommend IV fluorescein angiography to see if there's leakage. If leakage is present, it might be suggestive of activity and possible need for treatment. And so non-exudative choroidal neovascularization is a vascular lesion that we didn't even know existed because we didn't have the technology of OCT angiography to image it. So non-exudative choroidal neovascularization is a well-formed neovascular complex via OCT angiography imaging that has no signs of exudation via ophthalmoscopy, no exudate or hemorrhage that is, and there are also no signs of exudation such as fluid on structural OCT imaging and no leakage on fluorescein angiography. And I like to think of these as sleeping dragons because they could potentially wake up and become exudative in the future, even though they aren't right now. And this vascular abnormality is quite common. It's present in about 10% of intermediate AMD eyes in patients that already have exudative AMD in the fellow eye. Non-exudative choroidal neovascularization carries with it a substantial risk for conversion to the exudative form of the disease. So this is a risk factor for progression and vision loss. These eyes obviously then need to be watched very closely, and I also refer them for retinal evaluation and IV fluorescein angiography. Now I'm in a place where we don't routinely do it, but previously I was in a location where we would just do it ourselves, and that's what I would do. Much is still unknown about these membranes, but research suggests that the risk of conversion to exudative AMD in eyes with non-exudative choroidal neovascularization is about 15 times greater than those without. So you need to watch these eyes very closely.
Can I ask a question? This is Aaron again. We were just chatting a little bit earlier about how you manage a diabetic case in a primary care setting. You've got these cases, right, that are your moderate to severe dry AMD. They're high risk patients. You've got this, I think, a lot of really new and emerging evidence that Carolyn's presented here on managing these cases, because maybe you're not going to see this traditionally show up. What do you do differently with these patients? How might you approach them from a technology, from a patient management education standpoint?
Well, there's a few things. One is when you see a posterior epithelial detachment and you see subretinal fluid, that's almost to me diagnostic that needs to be treated no matter what we're seeing on the fluorescein or the angiography. The angiography portion of these examinations, if I see any evidence, and this has happened, I can't tell you how many times, when I refer this patient to the retinal specialist, that patient's there because they need to be treated. Often the fluorescein isn't going to pick up what I'm seeing in the angiography portion. So he will defer that to me and ask if I feel comfortable treating, and absolutely all the time. And then there's those cases when they get treated, and then when do you stop the treatment? Well, that's another good thing for the angiography portion. Say, all right, let's just sit back. Let's do this every 6 weeks instead of every 4 weeks, or maybe every 3 months, or let's just stop the treatment for right now and see what prevails in the future.
Yeah, I was just I wonder, how does that jive or line up with what you do, Carolyn?
I've started imaging all my patients with AMD, even if there's no fluid on just conventional structural OCT imaging. I image all of them with angiography to look for this feature of quiescent or non-exudative CNV. There are some situations where I'll just hold it in-house and monitor it. If it's a patient, I'm in a remote area, so if it's a patient that can't drive like an hour and a half to go see a retina specialist, then it's something I'm just going to hold in-house and monitor. I'd probably repeat the scan every 3 months if there's no fluid on top of it. So I think, the technology here really helps you hold on to cases up until the point of surgery, like Dr. Demko was saying.
Caroline, I'd like to add that I angiography everyone. So even the youngest patients, because once you get used to looking at thousands of angiographies that are normal, those subtle little changes that you look at a person and say, you know what, that doesn't look like the 1,000 people that I did before. And then you sit back and wonder, I wonder the clinical significance about this. But as the years go on, as you follow these patients, those little subtle changes, they paint a picture. It tells you what's going on with the health of that patient in general before any of this stuff starts to happen many, many, many years down the line.
You tie me in perfectly here to my summary slide, which is incorporate macular OCT angiography imaging on all of your AMD patients, even when the traditional macular cube scanning doesn't reveal any fluid, specifically to look for this new feature of non-exudative choroidal neovascularization. And if you find this non-exudative choroidal neovascular membrane, the next step is to consider IV fluorescein angiography. And if there's no leakage on fluorescein angiography, simply watch these membranes because we know that they're at risk for conversion. So you need to watch them pretty closely and definitely emphasize the importance of frequent home monitoring to catch the earliest conversion to the exudative form of the disease possible.
Good afternoon or good morning, everyone, wherever you are in what time zone. This is Dr. Stephen Demko, and I'm going to give you the overview on how to manage macular degeneration. What you're looking here at this slide is some of the test procedures that I use to manage, diagnose, and treat macular degeneration. Now, if you look at the slides, you would say, well, how do you treat macular degeneration with some of these procedures or technologies that you're using? A lot of the times when it gets down to the end of the case, you'll see a last note there, it says supplements. We will actually use supplements and different techniques, diet, nutrition, to manage our patients. But most of the stuff that we're using to diagnose them is going to come from one of these technologies that you see here. The major technologies that we're using are the OCT and the OCT with angiography, second with color vision testing and visual field, followed third with an ERG, followed fourth with maybe dark adaptation. We do transcranial Dopplers, and then depending on the visual field testing, color vision testing, we'll do VEP analysis to further manage these cases from a functional aspect. Here's our first patient. He's 56 years old. Here's a picture of his retina. It looks kind of normal at first. He's a financial analyst, but he is a tough person to analyze. He is tough. Lights bother him. He's sensitive to everything. So if you're going to do a clinical examination, a dilated fundoscopic examination without wide field fundus photography, you're going to miss a lot of things. For one, this is his right eye. When you look at his macula, there's no signs of macular degeneration. And you say, okay, he looks kind of normal. And if you did the OCT on this eye, it looks kind of normal too. But if you look off to the side, way into the mid-peripheral portion, you'll see some hemorrhages. And you're thinking to yourself, wait a second, I didn't see those hemorrhages when I was doing my indirect ophthalmoscopy. I wonder how I missed them. Well, tough person to examine. And the reason why I actually took this particular case is this is the routine. This is the bread and butter of our practices. These are the mild patients that you're going to see. And if you're not very, very careful, you're going to miss a whole bunch of things that you would never have saw before. So the reason for the peripheral vascular things is he has AIDS. He's has AIDS for about the last 22 years, managed well overall. His AIDS is no longer a condition as far as his maculopathy is concerned. So if we look at his retina of the right eye, you see an area and you're looking at that little spot there and you're thinking, okay, I wonder what that is. I've seen many of these in the past. Is this a lesion? Is this a maculopathy? Is it a window defect? Is it something from birth? Is it something that needs to be managed? Does it need to be followed? Is it going to have a pathological effect in the future? Well, let's go back. So you're thinking to yourself, okay, well, you do your refraction, you spend a lot of time on the refraction, and he refracts to about the same. He's still a little bit blurry compared to the other ones. The other side, his color vision test is about normal. And then you look at something else that I didn't put, which maybe I should have put on the screen here, is the ability to do wavefront technology. So with wavefront technology, I'm able to see if there are any higher order aberrations affecting his overall vision. In other words, does he have a cataract? Is there something in the cornea? Is there an opacification? How well is that light getting back to the eye? How is it compared to his other eye? In this case, his higher order aberrations are minimal. He should, based on the overall analysis, refract to an easy 20/20 without a problem. So we could be assured that it's not a problem that is refractive in nature or an opacification that's in nature. So now we look at the OCT. Here's the OCT of his left eye. And if you look at that area that we highlighted from that so-called window defect, we could actually see that that is a degradation of the retinal pigment epithelium. And furthermore, when you see that degradation and you see that image going down into the choroid capillaris, that further denotes that there is a problem with the retinal pigment epithelium and particularly the ellipsoid zone. So when you start to get the ellipsoid zone with that downward pattern into the retinal pigment epithelium, that's by definition, that's an optic atrophy. That is a problem that's going to produce either a decrease in vision. So if we look at his macular region, you can see from the slides from 2018 on the left to 2020 on the right, you could see some subtle changes in the macula, and he is starting to get some drusen in the nasal portion of the macular region, and there is some slight disruption. It's hard to see, but there is some slight disruption of the ellipsoid zone, which is of some concern. So here's a picture of the OCT of that area, which is kind of unremarkable. I could have shown you all the OCTs over the years, but it was interesting by looking at Dr. Major's presentation of how she went through all the different slides, all the different layers. And you could see off to the right, all the different views of this retina that are available to you. So it's not just one picture that you're looking at a montage of pictures. You're looking at different areas of the retina all the time and scanning through all these different areas, all the different levels of the OCT. And the thing to me that made this powerful is the use of form. Just very quickly, as I show you some of the slides that we're looking at, the different layers of the retina, and there's the functionality changes, but I'll quickly show you. So I'm able to go back through any year, any slide, any picture. That doesn't matter whether it's refractive status, his angiography status, the picture of the retina, the fundus photo, the wide field imaging, the angiography portions, the OCT. I could pick any year and put them together, which literally takes the snap of a finger. Back in the day when I had all this together, I would sit there with 4 different computers, 4 different computer screens in my office. So now with Forum, it makes it so easy. And the other thing about Forum, patients, they absolutely love the technology. They walk out of the office and they just say, wow, that was something that I've never seen before. So here's his ERG. Remember that area in the right eye that you could see he has a change in functionality. So on the left-hand side of the screen, that's his photopic negative response. That is more macula or retina driven than the right side. The implicit time, that's kind of used more for my diabetic patients to see how the overall flow of functionality is concerned there. But you will get some overlap. But you could see on the right side, on his A wave, there is a significant decrease in functionality, which is labeled in yellow. And of course, I went back through all of his other ERGs, put them up on the screen, and yep, there is a change. So now you can understand that there is a problem in functionality, and it is because of the drusen. It may be because portion from the retinal pigment epithelium. And before I go to the visual field, here's his ganglion cell complex. You could see the ganglion cell complex, that wedge, and that relates to that retinal atrophy that we were seeing. So that, of course, is part of the foveal region, and you can see adjacent to the foveal region on the right-hand side, there is a difference in the macular cube thickness. Interestingly enough, if there wasn't enough, look on the left-hand side. He has an increased cup-to-disc ratio. This does make him a glaucoma suspect just because of that. But if you look at the overall evaluation, you see all those areas that are gray. That means that he falls outside of the normative data pattern. So you can't use the normative data to manage this person, at least initially, as it pertains to glaucoma. So you kind of look at that, but you use his baseline over time, and you compare him in the future from where he was in the past. And you can see this is a recent slide that there is no changes overall in the retinal nerve fiber layer, and the change in that ganglion cell complex because often in a glaucoma's condition, you will get changes in the ganglion cell complex before the retinal nerve fiber layer. But now we could be assured, based on our overall analysis, that that ganglion cell complex is coming from a different area. That area is coming from this window defect. The interesting part of all this is sometimes you would never catch any of these things unless you had a little piece of technology. And one thing that I've started to do with all my patients is offer them a retinal health screening. We do this retinal health screening on almost all of our patients. There's a fee involved with this. And back in the day, and this has to be back 3 or 4 years ago, I would imagine, that Dr. Leck actually introduced me to this concept. And he actually requires all of his patients to have this technology done, or else he doesn't see his patients unless they actually say, yeah, I want to have this done, because he feels that this is such an integral part to his practice. And once I started doing that, I realized the same. Aaron, are you still requiring that on all of your patients right now?
Yeah, Stephen, it's funny you asked that question. I was because I was looking at what you were talking about on the slide where you were referencing the normative data pieces that were grayed out, right, in the one report around the optic nerve. So to answer your question really bluntly, yes, we're still requiring that, and we've continued to expand upon the technologies. And I think this piggybacks even on some of the stuff that we see little ways in which this gets applied in, even like, Carolyn, in your practice with the diabetics and things that you're talking about. You're now doing OCT angiography. There's not a code for OCT angiography. So a lot of these technologies are so new. So what we've done is, and this is across 4 doctors, so it's not just myself, but all of my colleagues that are in the practice with us, we do require that of every single patient before they come in. And at this point now, what we call our baseline imaging is ultra wide field fundus imaging. We do an OCT angiography as well as a standard MAC cube and optic nerve scan. So a 200 by 200 nerve scan that's referenced on the left-hand side of this image, the MAC cube that's there in the center, which gives us ganglion cell analysis, and what you see on the right, which is full macular analysis. And now we're adding to that OCT angiography. The OCT angiography right now on the 6000, we're using an HD. So their high definition 6x6 scan is our base. And then depending on whether they're diabetics, we stratify that just a little bit, or a diabetic risk kind of patient. So we've continued to evolve that piece, but I would tell you, Steve, like the biggest benefit has been normative data becomes this patient's normative data, right? The baseline data, as you showed in form, with all the information that you have there, we can form a story in which we compare a patient today to their norm and what that has been. And it has aided our diagnosis around AMD, glaucoma, and diabetes, and everything, where we're years in advance because we're relying on that data that we've been gathering since now. Our earliest scans are about 2009 and 2011 in earnest. So we've got somewhere around a decade's worth of information on many patients. And the other piece, and I'm sure you'll love this just from your expertise in practice management, it sticks patients to us, but it also makes for what we call a narrow front door. So patients know what we stand for when they come in. If they're getting a referral from somebody else to come and see us, they know they're coming into something special and different, and then they stay with us because it is different and because it does give them such a launch into the rest of their life. We're employing the technologies. And then the last thing I would add is, if any of my patients ever come over to your neck of the woods on the East Coast from the left coast, they are asking for offices that employ the same type of technologies, because they want to take that data with them and let it drive things, not their refractive data anymore.
Yeah. A few things to expand upon that. One, once your patients get used to this, it does become the norm. Everyone's shopping around these days because of the marketing, the advertising. Buy 2 pairs of glasses, get 3 years of contact lenses for free, and your first car. So this type of thing we're dealing with all the time. So one of your patients happens to stay out of your practice for a year or two. You walk in the door and you said, I haven't seen you for a year or two, and you have new glasses. Where have you been? And they just shake their head and they said, it's not here. We didn't realize what you had and what you were doing and the care that you were providing, as opposed to where we're going now. So now you have a patient for life. So that's the power of this technology. And back to your other question about the OC, just to go back on the screening, the only difference that I do is I've been using that new 12 by 12 cube. I am the proud owner of a new 6000, and I love it for a whole bunch of reasons, but the speed, the acquisition speed, and of course the technology in the anterior segment with the epithelial segment is just terrific in the practice. But other than that, the only thing I don't like, and I wish they would get a handle on this, is when you do the 12 by 12, it doesn't provide progression analysis with the old 8 by 8s or 6 by 6 that we were using before. So now we have to do all those and the 12 by 12. But I do use the 12 by 12 as my initial screening device for that. And on the other front, it's been 3 years now since we incorporated this retinal screening with the Zeiss OCT and the Claris wide field. And initially, it was very, very difficult. It was very difficult for my staff to get their arms around this. It was just another thing that they seemed like they had to sell. And then after a while, when you start picking up things that you never would have before, and right now, 50% of my patients get the retinal health screening, 25% of them, I have a conversation with them in the exam room about getting it. So our capture rate is about 75% right now. And the other 25%, yeah, I just do it anyway. I tell them I hope they appreciate this technology, but this year's on me. But next year, they're going to be required to have this so I can give them the best care, and they understand why. But the other take home of this retinal health screening is why it's so important. 25% of the time, we are picking up something that you never would have picked up before with your normal eye exam. And then that leads us into a whole nother segment of practice management, additional testing that you may do, but is most important, and which I'm really, really big on, is how to manage that patient from maybe we would call it a holistic approach. Talking to that patient at the end of the exam and saying, you are absolutely perfect, or you know what, you have issues that need to be addressed. Because if you look at our population today, you look at the obesity, you look at the high blood pressure, you look at the medications that these people are on, especially our older patients, almost everyone is taking something for something. It is having a big effect on my overall treatment program with all these patients with these simple pieces of technology that we're using. So the other things that we're using, and let's go back to managing here. He does have some macular degeneration. He's been putting on some weight lately. His body mass index has been going up. Maybe he's a glaucoma suspect a little bit. And, whether tests that I do on him that I followed up with, well, finally I talked him into doing MacuRisk, and that's an important part of my protocol. MacuRisk tells me the genetic percentile of the likelihood of getting a severe problematic case of macular degeneration in a 10-year period, and it gives me the likelihood and a percentage based on 0 to 100 of them getting macular degeneration, with 50 being the norm. So you could tell your patient you're more likely to get macular degeneration, and your susceptibility to it over 10 years is such. Then the other portion of it, the pharmacology part of it, is whether they should be taking zinc. I know there's a lot of people out there, so should be taking zinc, should you not be taking zinc, how much zinc, but this will give us an indication. Take zinc, don't take zinc, take a carotenoid, don't take a carotenoid, but it's just another piece of that puzzle that you just put together along with everything else that you're doing. And I know Dr. Major, she mentioned her transcranial Doppler, and she uses the 90%, if it's 90% blocked. I use something which is called the resistance index. That's the resistance of flow to blood in the eye. And I find this very, very valuable, particularly with my glaucoma patients. If their resistance index is above that value of 0.65, I'm more aggressive in my treatment than if it was below that 0.65. And I also use that with my diabetics and my macular degeneration. It gives you an indication of the health of that individual overall. All of these values, all my reports, they're all forwarded to their primary care physician. And if there's a serious problem with the transcranial Doppler, you will find the appropriate referral to the vascular person to manage them from a vascular standpoint. So after this is all said and done, and he says, well, how am I doing, doc? Like, what do you think about all of this today? I see there's some little changes in here. Do you think I need to be concerned? And I say, yeah, you need to be concerned because your macular degeneration is getting a little bit worse. Macular degeneration does lead to blindness. That doesn't mean that you're going to be blind in 10 years. Now, if you come back to me and you ask me, I'm losing my vision now, what should I do? And I would have said to you, I wish I would have saw you 10 years ago, because 10 years ago, I could have made a difference. I could have made a difference in your life to prevent this from getting worse in a whole bunch of different areas. And whether that's nutritional supplementation, which we offer at the practice, we have our patients come back for counseling. for dietary accounts, we introduce them to things like the glycemic load index, different things that they never understood before. We're talking about their diabetes and how to manage their A1C, what level that should be at, but particularly the macular degeneration side. So usually when we do the macular risk report that day when they come back, we go over that. Usually we'll go over the transcranial Doppler at that time, and then we'll do nutritional counseling and provide them with the appropriate supplementation that they need, which is usually a supplement such as MacuHealth. We do prescribe the different types of carotenoids for health. Macular degeneration starts somewhere. And if you're not careful and you don't pay attention to it, well, then inevitably what you're going to have is a situation like this. And you don't want to end up with macular degeneration like this, because this macular degeneration started just like yours. And then when you get down to the point where it needs to be treated and you're having injections in your eyes and the quality of your life is decreased because of that, well, then that is the reason that you need to pay attention right now to what you're doing, because you certainly don't want to end up with this, because this is a person that has been non-compliant. I've been managing him for 30 years. I've been having these conversations with him every single year. He's been lost to follow-up over time. And I know you haven't been here for a couple of years at a time, but now it's time to get on a regular schedule. I'm going to start seeing you every 6 months, and we're start doing a little bit more testing on you to make sure that this doesn't happen to you, because this could be absolutely avoided.
The real message at the end of the day is that this ties in, it loops the patients back into the importance of follow-up and their care. The imaging and diagnostic studies do give us an opportunity to see what's going on, but more importantly, it gives the patient an opportunity to understand at a level that they've never been able to visualize before, and they can now take charge, right, of their healthcare, as we are their co-pilots, right? We're reading the instrument panel and telling them what it means, but they've still got to fly the plane.
There's just so much stuff that's available to us today that we never had before, making all these diagnoses. Yeah, and I could sit in my room all day and look at all these slides and make all these calls and all that. But at the end of the day, it's how we relate this to our patient and what we do about it. And I think sometimes we miss the boat on that. And hopefully this message that I gave everyone today is give them a little better understanding that, yeah, there are going to be structural changes, but the functional changes and how they're seeing and how we measure and how we monitor this is probably just as important as what we do.
You've just shared some excellent clinical pearls. And my hope here is to bring this home a little bit with a little focus on inflammatory disease. We're not going to go as in depth because in our opinion and what we see on a day-to-day basis, when you are managing and now the primary eye care provider for the retinal conditions that have been discussed, the nerve-related conditions that have been discussed, you now start to become a bucket for many other maybe rarer conditions, more esoteric conditions, or maybe even the cases that you traditionally would see that might present as a uveitis, a traditional uveitis or iritis, have more to them. Both presenters here have talked about the inflammatory sort of pathways and components that are associated with the conditions that they're helping to manage or get in front of even. So as we look at this, I don't want us to become overwhelmed with inflammatory disease, although it can be relatively overwhelming when we consider what really is out there. And this is just a really brief slide around the differentials with regards to retinal vasculitis. You can see it's taken a whole bunch of time to load this because the differentials are both systemic and ocular or ophthalmic in their presentation. And when it comes to knowing what's going on, it's not necessarily being an expert on all of these conditions that are listed, but understanding what's really happening at the basic levels in the retina, in the optic nerve, and even somewhat tying that into some very basic scans and ability to image the anterior chamber. So what I hope to do with the next few moments as we take this is to talk about OCT and retinal inflammation, OCT-A and retinal inflammation, or OCT angiography and retinal inflammation, and then OCT anterior segment OCT applications and inflammation that would happen across the eye, but particularly with regards to retinal inflammation. These next couple of diagrams or slides that we're looking at were first published in the Clinical Experimental Ophthalmology Journal, and I've referenced that here because I think that it's a really useful place to go in addition to the information you're getting here to read in more detail. And there's a ton that's in that particular publication around this, but I want to focus for a few minutes on what's happening and what we can see, or how the tools that are in front of us help us to manage it. So you'll see in this slide, we've got A, B, C, D, E, and F that are labeled, and those are labeled on purpose. And I want to draw your attention to a few things in each of them. You're looking at an OCT-B scan or tomogram in the top 4 images, and in the side, a couple of images that are there of the optic nerve. You're looking at both an image of the optic nerve, a topographical or a nerve fiber thickness map, and then a tomogram or B scan there to the right. So it gives you a little bit of visualization of the various cross sections of these 3-dimensional components. But starting with what's labeled A there in the upper left-hand corner, what you'll notice is that the vitreous, which normally is relatively clear, as contrasted with the image that's just to the bottom right below at image B, those are actually of the same piece of the same retina. And what you're seeing in the first one is what will, if you have a posterior uveitis, where you're going to typically see change that occurs, and that is going to be vitreous cell and flare, kind of this almost like looking through headlights in a fog that patients may describe, and they may not describe it. So it's important, as we have these technologies, and similar to the doctors that are on with us today, we use a Cirrus 6000, and the imaging of the retina, especially when you're looking at some of the scans around the single segment scans using enhanced depth imaging, you're getting an amazing view of the vitreous now, in addition to the retinal tissue and the sub kind of choroidal tissue as well. In A, what you're seeing is hyperreflectivity, that's cell and that's flare. And in B, what you're seeing is the resolution of that. So now in a panuveitis where you've got retinal inflammation and you've got vitreous inflammation, you're able to contrast those two pieces and really see, is the treatment working or not? And we're not speaking to a specific condition here, but you can see, especially if you've got at your fingertips the opportunity to treat, you've also now got the opportunity to see and demonstrate resolution on a quick snapshot. In C and D, that's on your right-hand side, we see a secondary piece that can be evident in uveitis, or especially in a posterior retinitis or uveitis, and that is choroidal thickening. And the choroidal thickening occurs for a couple of different reasons, but you can follow it through to just think about what's happening with blood flow. And in the acute phase, you've got increased blood flow, the inflammation that's there, and you'll see this little white line that's demarcated. It's just meant to demonstrate the margins of the choroid in relationship to your sort of interretinal layers there in your RPE. And you can see in D, where as you're treating the uveitis, the retina is starting to go back to a normal shape, particularly at the region of the choroid. And so contrasting those pieces, when you use EDI or enhanced depth imaging, that technology allows you with confidence to understand, yeah, I am having an effect here. And then the last one, and this is where I think baseline, using a baseline retinal and nerve image can be really helpful, is sometimes the swelling around the nerve isn't as demonstrated as it is here in this figure E. And what E is showing is you've got a really large amount of edema around the optic nerve, again, which is consistent with all the other findings. You can see the swelling on the B scan, and then you can see that resolution that occurs in F, but sometimes this is much more subtle. And so if you were in a situation where you had baseline imaging and a patient that was reporting some of these early symptoms, or maybe had a condition like I listed on the very first slide, that would give them maybe a preponderance to having a uveitic or a retinal sort of inflammatory condition, you're oftentimes going to see this on the optic nerve, and it may be subtle. It may be a 15 micron swelling rather than 100 micron swelling or difference as you see on the images here. So that's OCT and retinal inflammation in a really brief nutshell. But as you can see here, you're using single line raster scans. You could use a cube scan in this. You can use a nerve scan. And they all start to talk to each other and inform a bit more about what's going on. But let's take it a step further. Let's add in this technology around OCT angiography. And you've seen a lot of images around that here on the presentation. I'll just highlight a few things. One, in A, you're looking at traditional CME. And so what happens when the inflammation associated with the CME begins to resolve is we get the image now that's on the right, or what is labeled as they're pointing to the epiretinal membrane. There's a lot of different ideas on how epiretinal membrane forms, but one of the things that we are seeing more and more, and you'll find evidence for this quite a bit in some of the literature, is that these epiretinal membranes may be a result of inflammatory chronic inflammation in processes in certain types of patients. So the epiretinal membrane, which we just used to look at and kind of pass off, is starting to gain traction in the retinal space around its indication around chronic systemic inflammation. And so we have to be more attentive to that, because now we have diagnostic capabilities that allow us to identify that early. And then just a step below there is looking at, as you've already seen demonstrated on a couple of the other cases today, but it's demonstrating this as a situation of CNV, right? Where you can now image, and you don't just have to look at the B scan and say, well, there's some thickening in the retina there, but in this particular case, there's neovascularization that's occurring, and that's what you're getting, that second segment. So you're looking at a B scan and compared to an en face view, a very specific area to the choroid, and showing this choroidal net or neovascularization. And what I'm highlighting for you here is because these things can also be present in these inflammatory processes with regards to uveitis and retinitis. So something, again, to keep in mind. And then the last one that I want to keep in front of us and to think about, because this is really the newest wave in the technology, and that's around anterior segment OCT. You used to have a device that was set aside only for it, and now you've got in your devices, and particularly in the Cirrus and the 6000 and the 5000, you've got this capability around anterior segment imaging. And what you're seeing here are a few different things. So in the top, in A, you're looking at cell, actually imaged cell in the anterior chamber. In B, you're looking at keratoc precipitates, which you'll be able to visualize from the front of the eye. And this doesn't substitute for your slit lamp or biomicroscopy exam, but you can now measure where those pieces are at. And forget about counting cell anymore. You can count cell using an anterior chamber scan. And then the bottom one with C is just showing the adhesion that's posterior on the iris there to the lens, so posterior synechia. In this case, OCT has application in traditional retinal scans. It has application in your traditional nerve scans. We've got then single line scans, which give us an amazing amount of view of both what's happening with maybe serous fluid versus other inflammatory components in the retina. And then in the OCTA in the previous slide, you're actually seeing and able to image the results of these active inflammatory conditions. And here on anterior segment OCT, we see the signs of inflammation within the anterior chamber that also has spillover into that posterior chamber. So what does this mean for me, and what do I really need to look for? And I want to just summarize that in some very, very basic terms for you, because I think there are three buckets when it comes to retinal inflammation that as a primary care we need to be alerted to. And then I'll end with one other set of suggestions or recommendations on other conditions that can seem like they're inflammatory. So here we are in retinal inflammation, true retinal inflammation. We know that in uveitis in particular, that 20 to 60% of all posterior uveitis cases are caused by toxoplasmosis. Now, it's helpful to understand who that group of patients might be. And it's also helpful to understand not just that you're looking at 10 to 35-year-olds in most cases, but toxoplasmosis can have recurrent exacerbations. And I won't go into all the treatment and management of those conditions, but starting here, recognizing that is, if you're falling into that camp, you're usually dealing with toxoplasmosis. It could be toxocariasis. There are viral mediated and fungal and spirochete mediated retinal inflammatory conditions. But for the lion's share of us who are in the primary care setting, if you're seeing it, it's most likely in a posterior uveitis situation, you're dealing with toxoplasmosis. And so do you feel comfortable or not handling that? There's a lot of good clinical data that indicates the treatments, and the treatment falls well within the traditional optometric purview and most of scope legislation that exists across the US. That being said, you've got to have the tools in place to be able to measure both what they have to begin with and what the resolution should look like, and at whatever point it needs to, if it's not responding the way you think, that patient is out of your chair. So that's the retinal inflammation kind of summary slide in really basic format. When it comes to the other conditions that are out there, I think that it's really useful just to keep in mind that some other conditions can have inflammatory elements to them or look like they are inflammation. And those are maybe an AMD situation. And we saw some great images just a moment ago with regards to RPE, like a pigment epithelial detachment. CME can have inflammatory sort of components associated with it in central serous. And so I'm just going to go really briefly through a very basic set of slides that demonstrate some of the technology that Steve was talking about just a moment ago. First one here is a case of AMD. And in this particular case of AMD, you see a pretty significant pigment epithelial detachment. This is in the newest versions of Retina Workplace and Forum. On the left-hand side of this image, we're actually looking at the OCTA image. In the center or the right-hand side of that image, you're looking at the OCT structural image. And then to the right, you're in the upper right-hand corner, you're looking at the B-scan. And Steve highlighted this before, but I think is great, is that this is really a dynamic scan. You can go into any of these boxes that are down below and click into these, and the imaging that you're looking at will actually revert or go to that particular subsection that you want to pay attention to. So whether it's your superficial or your deep retina, if you're looking at the outer retinal choroidocapillaris complexes, whatever you want to see, you can typically get. And then you can design your own around that as well. Where if you didn't like what the instrument was giving you, for example, you've got a big black spot that's sitting in the middle of this, and you're going, wow, I don't see that when I look at the retina. Nothing really looks horrible, but you see that the actual segmentation lines are cutting through nothing, which is why it looks like there's nothing there, when in all reality, and looking just above it, you do see that there's a lot of retinal tissue. So that's something to keep in mind on these slides. You can also combine your retinal images now. So what you'll notice here is this is actually a Claris ultra wide field image that has been taken in the upper right-hand corner. The artificial intelligence now does such a great job of being able to drop that image in. It registers it against the retinal image, the retinal vessels from the OCT image that was taken, and then these two become combined. And so you can play with transparency, you can image and view what's going on at different levels of the retina. And then in this particular case, it's following this patient over time. And this goes back to the practice management piece, where when you have data that is early on, mid-stage, and then late stage, you're able to kind of manage that patient all along. And this patient is going to be a long-time patient of the practice. You can see this was just taken in March of 17, and in August of 2019, this was mid-treatment. This patient actually, from their initial visit that's on the left here, progressed pretty rapidly. And within 6 months, went from a mild case of age-related macular degeneration, non-exudative to exudative. And you can see how the technology allows us to see kind of what's happening as this patient goes along. And here's just another demonstration of these multimodal technologies being combined together. And this is all within Forum. You've got the 6x6 OCT that I was referencing a little bit earlier. You can see the level and density of the data, the information that's in this, as well as the Claris ultra wide field that sits behind us. The next case is a CME case, and in this particular case, he was a patient who we had seen post-operatively. He was actually in pretty darn good shape. That's just an ultra wide field of him, and I'll flip back to one more little image here, see if it decides to click in. Maybe it won't. What particularly we want to focus on is what's happening here in the central macula. It really didn't have a petaloid appearance to it at all, but something in his particular case was off. Vision was off, and we actually found that he had CME post-surgery. He had gone through a set of treatments, so you can see this is in the month of December, and in quick succession, he had actually gone into retina. Retina wouldn't treat him. First said, yeah, keep taking your steroid drop and your ketorolac. And we had already known what was going on with him. We sent him back 2 days later, and he got his injection. And you can see that 3 days post the injection, a lot of this stuff had resolved. But this was a gentleman that we had baseline on, and we continue to follow. And what you see here is that all this stuff kind of changed. And so his final resolution is here in March of 2020. And you can see that over a period of about 3 or 4 years, we had to manage this chronic inflammation with this individual. But the technology allowed us to confidently do that. The patient was coming back to us for regular visits. And really, we were piloting his management. The patient was very appreciative of that because he was part of just a cattle call at Retina. And the last case here is just a central serous. And in this, again, we see these combination of modalities. Here we have an older VisuCam photo that was taken, and we're overlaying our current retinal analysis on top of it. This is a situation in which we were able to analyze and look at this from different modalities and different viewpoints, see resolution that's happening over time, and confidently manage the patient. So this was a patient who clearly the central serous had progressed. It had dropped down into the center of her vision, where early the morphological changes weren't quite there. She really appreciated, again, through this from a practice management standpoint, what it meant to be cared for. So in summary, OCT and the technologies that we've highlighted here allow us to really manage these cases and differentiate the last few cases, which are much more common to our practices, from the first cases that we were talking about retinal inflammation. And I think it's really important and critical that we learn to use all the components of OCT and don't just fall into one bucket of, well, I just want a macular cube and I want a glaucoma scan. This technology combined with wide field and ultra wide field imaging and all of the other devices and components that my esteemed colleagues on this webinar have referenced, that's really where it is learning how to use all those tools and tie it all together to give us a great clinical picture, and our patients will be the beneficiaries.